Buzogany is with us this morning. Good morning.
Good morning.
It's been a while since we've had you in the studio.
About 5 years ago.
Yeah. Well, we gotta rectify that first off the bat. Get you in here more often because we've got things to talk about with you. Primarily today, we want to focus upon suicide. This is Suicide Prevention Awareness Month, and you and Dr. Ralph May had that program at the Rustic Lodge a week or so ago. And,
that's correct.
And that was an interesting topic to me, but for a lot of people, that's a topic that there's a natural automatic barrier that goes up. I don't want to talk about suicide, is the reaction that a lot of people will have when that topic is raised, isn't it?
It's a scary thought. It's a scary topic. Nobody wants to think about their mortality. Also, it signifies weakness in somebody. Nobody likes to see that. Nobody really likes to deal with that. Mm-hmm. And a lot of people just simply don't know what to do, how to react to someone who is suicidal or very depressed.
Yeah.
It's sort of like when someone has a loss in their life, okay? Mm-hmm. Other people just don't know how to behave a lot of times. Obviously, trained professionals do, but I think that's a lot of it.
People have that stigma that is attached to it, number one. But let's look at it from two different angles. The person who is contemplating suicide, and let's focus in upon that person first of all. Warning signs that others might see in that person. Are there definite warning signs? Are there signs that would indicate that it might be? I know it's kind of hard to say it's a hard and fast rule in any given area of practicing medicine, but talk about that for a moment or so.
It's ambiguous. And it depends on the person. Everybody expresses themselves in different ways. People suffer depression. There are consistent signs and symptoms that we look for, but people experience it in a different way. So it's pretty hard to pin down a person who is suicidal. For physicians, the cardinal rule is know thy patient. Get to know the person that you are working with so that you can recognize these signs. Family members, loved ones should already have an idea. Consistencies, typically inconsistencies are what you're looking for, okay? A change, a distinct aspect change in the loved one's behavior. Nihilistic thinking or negativistic thinking. What happens with a person who begins to enter into the realm of suicidality, their depression causes them to narrow their scope of the world to the negative spectrum, to the point where the null option becomes a possibility. And what I advocate doing is don't let that person get to that point.
Okay. Keep it broad. Don't allow them to narrow it down. BHS Neuropsychiatric Associates is your practice, and it's on the IRMC main campus, is it not?
That's correct. I'm the director of mental health sciences. So we have a 16-bed geropsych unit, a robust outpatient practice, consultation liaison service, a Suboxone program, and an academic program.
The people who come to see you and to receive treatment from you, generally self-referred or generally somebody has convinced them to come and comes with them? Yes.
Okay. So we have, and provider referred.
Okay.
So I get a lot of referrals from my friends in the primary care community. What's nice to see is more self-referrals than I've seen in previous years. So the stigma of mental health seems to be fading somewhat as more education and information is out there.
Well, that's neat because that means that somebody is recognizing, I have a problem, I need to address it now. And obviously the earlier they can do that, the better.
Absolutely.
Yeah, okay. So when someone does come to your offices or to see someone for psychiatric services in general, the idea of that person coming in to see you is a hurdle that has to be overcome first of all, and for them to be there means that they've taken that positive step.
Nobody goes to see a psychiatrist because they're curious. Okay. They go because they're in serious trouble.
Absolutely. All right, so let's talk about that person again who has contemplated suicide or has begun to think of it as a possibility and a way out. It's not really a way out of anything, is it?
Depends on your perspective.
I guess so.
There's a lot of different perspectives on this.
Mm-hmm.
And in some cultures, it is accepted. It's an acceptable practice.
Mm-hmm.
In others, it is not. We are having a lot of changes in the way we're looking at it, from euthanasia and things like that, all the way up to physician-assisted suicides out west.
Yeah.
But in general, from my perspective as a physician, psychiatrist, it's not acceptable.
People around a suicidal person, misconceptions that they might have. If I say something to them about it, if I ask them if they're contemplating suicide, it's going to lead them to it. Is that a misconception?
Yes. What I said at the meeting was, I ask all my patients, even if they're completely baseline and doing very well and everything is fine, I still ask them, are you suicidal or are you homicidal at every visit? And a lot of them ask me, why do you keep asking me that question?
Oh, yeah.
There's nothing wrong with them doing fine. And I said, because there's times when someone says yes.
Mm-hmm.
People will show up at their physician or psychiatrist's office with an incredibly well put together and constructed facade.
Mm-hmm.
You would not be able to tell what's going on behind their eyes if they didn't want you to.
Mm-hmm.
So I always ask. And there are instances where the facade shatters immediately when I ask the question.
Yeah. Wow. For someone who is in that situation of seeing someone who seems to be on a downward spiral, what are the things that they should say to that person?
Talk to them. Say something.
Mm-hmm.
Go up to them and express your concern. Try to bring it out. The time to intervene is not when the person has a .45 in his hand pointed to his temple. Okay, the time to intervene is way before that. Look at the warning signs. Depression, listlessness, lack of interest in doing things they normally like to do. Isolation is a big one. Probably the most statistically significant is hopelessness. We see that throughout the years when a patient expresses hopelessness, that seems to be a harbinger of things to come.
Mm-hmm. The idea of prevention of suicide and intervening in a suicidal situation, Indiana County has undertaken a massive training program for folks to be able to recognize those signs and those symptoms. Could you talk about that for a little bit and how it is that people can become involved and what it becomes their responsibility to do?
Well, we have a very well-developed crisis intervention system through the Open Door. We work very closely with them and the emergency department and law enforcement. Mm-hmm. If there's a situation in the household where someone is actively suicidal or expressing suicidal thoughts, call the crisis hotline. Mm-hmm. Don't try to handle the situation yourself if you're not prepared to do so. When my primary care doctors have a suicidal patient in their office, they call me and ask me what to do. I tell them, send them to the emergency department or call 911. Mm-hmm. These are people that are trained to handle that situation. The crisis intervention team will then make an assessment as to whether or not this person needs to go to the emergency department for further psychiatric evaluation. Mm-hmm. We have a really well-developed system here in Indiana County. It's reassuring.
Does our county differ all that much from surrounding counties or some of the bigger counties where we might think that there are more professionals in place?
We have less professionals available to us than, say, Westmoreland, Allegheny County, obviously, because the population density is much higher and there's more professionals over there. But it does seem that the professionals we do have available happen to be really good at what they do.
Yeah, yeah. The prevention number you mentioned is 1-877-333-2470. 877-333-2470. It's available 24/7, 24 hours a day. 7 days a week. And we talked earlier about warning signs for suicide, warning signs for depression. People might not recognize those, the warning signs of depression. Does depression always lead downward, or is there a way up out of it? In other words, maybe I'm not phrasing that correctly. Someone is depressed. Can they get themselves up out of that hole without the risk of going right back down into it?
Of course. Depression is treatable. Someone once told me that if you don't do anything for a depressed patient, the depression would lift eventually, about a year. However, the reason we treat is because of the risk of suicide.
Yeah.
So we can get someone out of the depressed state 10 to 14 days, a couple more weeks with antidepressants. The nice thing about the current psychotropes is they actually work, and they make a difference. It's not just depression that is at risk, that causes a person to be at risk for suicide. Bipolar disorder, to me, is worse. The problem with bipolar disorder is impulsivity. People with bipolar disorder will be cleaning their gun, and suddenly the idea will pop into their head, what would it be like, and will do it. I've actually had, not my patients do it, but I've worked on cases where that did occur. It's an extremely frightening thought that can occur. Alcohol, substances, you can just magnify the danger by tenfold, or the probability. When you combine a psychiatric illness such as bipolar disorder with substance abuse, the risk is astronomical. It's very, very serious.
Yeah. What about brain injury? Someone who has suffered a traumatic brain injury.
Impulsivity is a key word. When you suffer a traumatic brain injury, depending on what kind of brain injury it is, one of the first things to go is your inhibition. You become impulsive. You lose your brakes. The brakes go bad. So whatever pops into your head, thought, idea, task, you may just randomly do it without thinking of the consequences. That's a problem with traumatic brain injury, but that's very similar to what goes on with bipolar disorder. The traumatic brain injured also can look like they're bipolar or look like they have intermittent explosive disorder for that very same reason. So their behaviors can be turned inward and turned outward.
Yeah. We haven't talked about PTSD, but obviously that plays a big role in the suicide numbers as well, too.
Yes, it does. And again, it depends on what the trauma was. How the person went into the trauma psychologically. In other words, the term we use is schemas, your sort of paradigm that you have operated with throughout your life. And what your genetic loading, your experiences that have happened to you form these schemas. When you go into a traumatic event, how solid you are going in will predict how solidly you'll come out. If you've been victimized in the past and you're depressed and you suffer from a mental illness and you go to a traumatic event, it's pretty obvious you're going to come out on the backside pretty messed up.
Yeah. Dr. Joseph Buzogany has been with us here today, and our segment is very, very serious, and that's with a reason. I mean, this is Suicide Prevention Month, but suicide is not just a September thing. It's an all-year-long thing. It's every day. It breaks down every barrier of society, ages, incomes. Everybody is susceptible within every strata of society, are they not?
That's correct. Absolutely.
1-877-333-2470. That's the crisis intervention hotline, available 24/7. 877-333-2470. Thank you so much for coming in to visit with us today.
It was a pleasure.
We appreciate it. I want to come back someday and talk about, well, maybe not more pleasant, but certainly any topic is going to be more pleasant. But there are other things that you do in your line of work that can help people in their lives as well. So we'll get you back.
I would enjoy that.
It is the voice of Indiana County, WCCS, AM 1160 and 101.